series. Good afternoon and welcome to our webinar series. We'll be starting in 1 minute. Thank you for joining the call, and we allow others to join us at this time. Thank you. You are in listen-only mode.
So there's nothing being said right now for the person who said you can't hear anyone. Can you hear me talking now?
Yes.
Mm-hmm.
Yes. Yes. Hello?
Yes.
Hello?
Yes.
Okay. I just want to know if you can hear me.
Okay. Good afternoon. Good afternoon. I'm Al Richmond, Executive Director of the Community Campus Partnerships for Health. It is with gratitude and a deep sense of shared commitment that we welcome you to Communities in Crisis, Ensuring Equity in the Time of COVID-19. This webinar series is sponsored through a partnership between Community Campus Partnerships for Health and the University of North Carolina Center for Health Equity. We're also grateful to have the co-sponsorship of the Robert Wood Johnson Foundation Clinical Scholars Program. Today's session is in response to the global COVID-19 pandemic. Designated as a global pandemic by the World Health Organization, this health crisis has mobilized our attention to the pain, suffering, and death attributed to COVID-19. We believe that our collective pain must catapult us forward in supporting our communities. This moment in time will be remembered in history for its global impact. And putting this in perspective, I want to share some numbers with you. In the United States alone, over 615 individuals have been diagnosed with COVID-19. 49,000 have recovered, and we mourn the death of over 26,000. Worldwide, over 2 million individuals have been diagnosed with COVID-19. 500,000 have recovered, and 128,886 persons have died as a result of this globally. Today's session is a fast-moving time together. Before we start, we have a few ground rules. Your audio and phones will remain muted for the duration of the call. Questions to our speakers may be placed in the chat box. We are working to curate your questions. We've also shared the questions that you've offered as part of the registration process with today's discussants. Today is the start to what we anticipate to be weekly conversations. It is our hope that we will be able to dive into the multi-layered issues associated with COVID-19 and equity in upcoming sessions. This webinar is also being recorded and will be available tomorrow on the CCPH and CHER websites for review and to share with your partners. We invite all of you to follow us on Twitter with #EquityCovid. Joining me today as co-moderator of our session is my longtime academic partner and colleague, Dr. Giselle Corby-Smith, Professor of Social Medicine at the University of North Carolina at Chapel Hill. Giselle is also the director of the UNC Center for Health Equity and Research and co-lead of the Robert Wood Johnson Foundation Clinical Scholars Program. Giselle?
Al, thanks so much, and welcome to each of you to being here. As Al said, the outpouring of interest in this work has really been galvanizing for us as we've thought about this webinar and seen this pandemic unfold and seeing it actually impact disproportionately disparity populations across this country. Our learning objectives for this series of webinars is to really share the perspectives on COVID-19 and its impact on health equity and disparity populations in this country. Through this webinar and the over 300 people that have registered for this webinar, to develop a network to support systemic changes in response to COVID. And finally, to explore collaborations and partnerships that are promoting health equity and the response to COVID-19.
Thank you, Giselle. We're privileged to have as our first discussant, Dr. Kamara Jones, who is currently the Evelyn Green Davis Fellow at the Radcliffe Institute for Advanced Study at Harvard University, past president of the American Public Health Association, an adjunct professor at the Rollins School of Public Health at Emory University, and senior fellow and adjunct associate professor at the Morehouse School of Medicine. Kamara, as a friend and colleague, I'm always impressed with your ability to demystify what can be complex subject matter. Please help us out today by sharing a brief overview of COVID-19 and how we arrived at this point in our global experience with the disease.
Thank you. Thank you, Al. Thank you, Giselle. And I'm going to start sharing my screen. And I have to say that many people know me for my work on naming, measuring, and addressing the impacts of racism on the health and well-being of the nation. I'm also an epidemiologist, and what I'm going to share today is actually kind of an Epi 101 to level set so that we all have the same understanding of what's going on. And I will interject at different times some of the questions that are still out here for us. So what I'm going to first present is an infectious disease timeline. And when epidemiologists talk about infectious diseases, we talk about a triad, like 3 things that are required. There has to be an infectious agent. And the one that we're really concerned about right now is, at the beginning, was called the 2019 novel coronavirus because it was new. We had seen coronaviruses before in terms of SARS and MERS, but this was a new coronavirus, which eventually got the name of SARS-CoV-2. So when you talk about the coronavirus or SARS-CoV-2, that is the actual RNA virus. Then in this triad, you need a susceptible host. The first susceptible hosts were horseshoe bats. And then people think that maybe it got from the bats to pangolins. And you're like, what is a pangolin? Well, it's sort of an anteater looking thing that lives in trees. But from there, it got to humans. And now humans are a susceptible host. In December of 2019, not a single human on Earth was immune to this disease, which brings up the question now, why are we seeing such disparities in terms of infection rates and death rates among Black Americans in this country? Because if there's everybody's equally susceptible, and if opportunity were equally distributed, and if exposure to risk were equally distributed, we would not expect to see, any way you sliced and diced the population, any differences in terms of outcomes. So there we go, that big if. If opportunity were distributed equally, they are not. We have a system in this country of structuring opportunity and assigning value based on so-called race. We call that system racism. So what we're seeing there is a huge impacts of racism, but I digress. The third element of this triad, this infectious disease triad, is a favorable environment. So for bats, it was bat caves. And then it had its first, as far as we can tell, kind of expression and jumping from the bats and pangolins into humans at a wet market in Wuhan, China. And what is a wet market? It's just basically where animals might be slaughtered in front of you or whatever. It's a wet market as opposed to a dry market that might be selling books or fabrics or that kind of thing. And now the favorable environment is in your community, my community, all of our communities. And this is the problem. When you have an infectious agent and a susceptible host in a favorable environment, you also have to have exposure in order for the disease to get into the person. And we are right now trying to interrupt exposure. In fact, this disease really has a public health cure to it. We're treating it now as if it were a medical disease when actually it's a public health disease, and our medical treatment of it is interfering with us curbing the spread of the disease. I'll talk about that more. So the exposure things that we know now, hand washing, wearing face masks, and beyond that, not touching your face. My colleague Phil Wilson, who founded the Black AIDS Institute decades ago, says the main thing is do not touch your face. Don't touch your mouth, your nose, or your eyes, because that's how the virus gets inside you. It doesn't go in through cuts in the skin or anything like that. Social distancing, which has now resulted in us shutting down our schools, and people are homeschooling if they can, shutting down many of our businesses. People who are able to are working from home, but those who cannot work from home, either because their jobs are frontline, front-facing, and if they're going to work, they have to be at work, or because they might want to work from home, but they can't afford to do that, shelter in place because they don't have enough money to pay the rent or for food, and they don't have paid sick leave, all of that. So social distancing, which is working out in our current time as being for some, especially the shelter in place stuff. So the stay-at-home policies are working for some. And then isolation centers and quarantine, which we haven't really implemented yet in the US. But the idea there is if you know somebody's infected or has even been exposed, instead of sending them back to their home and asking them to just sort of stay away from people in that small apartment, maybe 3 generations, actually in China and in Singapore and Taiwan and other places that got a good lid on the infection, they actually made it possible for infected people to go to some other place, like a hotel, where there might be nurses there kind of monitoring them and making sure they're okay and sending them to the hospital if they got worse. So here we now have infection. And now I'm going to talk about the infectious disease timeline from the point of infection. So the infection, the virus itself, we call it the 2019 novel coronavirus, or SARS-CoV-2. The infection itself is called coronavirus disease 2019, which we shorthand as COVID-19, COVID-19. So that's why we talk about COVID-19. The virus is not the same as the disease. This infection has some kind of incubation period. All infections do. And the symptoms, if they show up, some people do not have symptoms, but they can include loss of smell, they can include fever, dry cough, chest tightness, shortness of breath. Especially if you get to the point of the fever and cough, you should first call your provider and tell them that you're having these symptoms, especially if you're over age 60 or you have any of the chronic diseases which are causing people to get more severe forms of the illness, which include diabetes, heart disease, renal failure, asthma, hypertension, all of that. So these are possible symptoms, but note that I said some people have no symptoms. But if you do have symptoms, then after the point of symptoms is where we call clinical disease in the generic infectious disease timeline. So the clinical disease can be something like a flu-like illness, or it could be pneumonia with the flooding of the air sacs in our lungs with this viscous liquid. And that's why so many people are being put on ventilators, because it's hard for them to get any air, oxygen exchange in their lungs, because the air sacs in their lungs are filled with liquid. The outcomes at the end of clinical disease could be full recovery. And thank goodness, many people have this disease and are recovering. It could be, we don't know, because we don't know enough about this virus yet, possibly persistent infection, because we do see persistent infection in other diseases. We see chronic infections in terms of HIV, where people just have, they have the infection in them, and now it's become a chronic disease. There's latent infection, which sometimes tuberculosis, you're infected, but it doesn't show up for decades. There are carrier states. So some people carry the bacterium that causes meningitis. They never have meningitis, but they're carrying that bacterium. Or they carry the bacterium that causes strep throat. So we do not know if there's anything like persistent infection with this virus. There might be, because there have been people who have tested positive and then they've gotten over it and they've tested negative, but then on a retest, they've tested positive again. So we do not know. And unfortunately, death is also an outcome. From China and from South Korea and some of the other countries, death was occurring in about 1% of the people that they knew to be infected. In Spain and in Italy, it's looking, when I just looked at the data a few days ago, about 4%. We actually are in the middle of our pandemic, so we can't tell. But the thing that has caused so many alarms for us is that when we do look at the racial ethnic distribution of those who have died from COVID-19, in Chicago, 70% of the deaths were from COVID-19, although in Chicagoland, I think maybe 23% of the population is Black. In Louisiana, it was again 71%, with a much smaller proportion of the population. So this is what's rung the alarms, and this is why we all need to name racism as the root cause of that. But we can ask and answer questions about that. Getting back to the infectious disease timeline, in most infectious diseases, it is thought that you start becoming infectious, that is, able to spread the germ, the virus in this case, or the bacterium outside of you and affect other people shortly before you start developing symptoms. But actually, with this disease, we have no idea how early after you get infected you can start spreading the disease. And it's especially important to know that with COVID-19, you can spread this virus without ever feeling sick. So that is we think that up to at least 25% of the people who get the virus never have symptoms, and these are the asymptomatic spreaders. That's why a different strategy to testing, not just testing those people who have symptoms, but testing a sample of the whole population, including testing asymptomatic people, people who do not feel sick, is important for us to understand how widespread the virus is in our communities. That knowledge will help us predict where we need to put our health resources in 2 weeks, because what we see in the hospitals is a 2-week-old picture. That's where the virus was 2 weeks ago. It's like a very slowly developing Polaroid picture, right? So testing asymptomatics will let us know where we have to put our resources. It will also enable us to get the asymptomatic spreaders and isolate them so they stop their spreading, and also find out who are their contacts. Let the contacts know that they've been in contact with somebody who has the disease, and have them isolate as well, so we interrupt that second generation of spread. So what I have now is a riddle, okay? Here's the riddle. On day 1, a single lily pad is planted in a large pond. This lily pad is a kind of pad that reproduces very quickly, doubling itself every day, so that on day 2, there are 2 of them. On day 3, there are 4 of them, because each of the 2 doubles. On day 4, there are 8 of them. On day 5, there's 16 lily pads, and so forth and so on. If I tell you that the pond becomes fully covered by lily pads on day 48, I need to ask you, on what day is it only half covered? I'm going to give you like 2 seconds to think about this. 2 seconds are over. What is the answer? The answer is on day 47. On day 47, it's only half covered, and by day 48, boom, the whole thing is covered. Actually, on day 40, if you were to look at that pond, you wouldn't even know there were lily pads there. This is just to help you understand how exponential spread works. And that is what's happening with this virus. In fact, if I wanted to give you like a little grid to show you about exponential spread, let's say we start at day 0 with 1 person who is infected. In this country, the doubling time, with the lily pads, the doubling time was 1 day. With this infection, the doubling time in the US at the beginning was about 3 days. I don't know if it's gone down to 2 days or where it is right now, but we're just gonna say it's 3 days. So if you start with 1 person on day 0, on day 3, 3 days later, you'll have 2 people. And you notice the one who I started with, I've colored them all red now because they can't be infected anymore. They're either going to be recovering or dying, but they're going through their course of disease. On day 6, this is what it looks like in my little population grid. Day 9, day 12, and day 15, in just 2 weeks' time, and there were more infections that I couldn't put because I don't have a 64 things in my grid. But in just 2 weeks' time, or 15 days, the whole population has been infected. In 2 weeks' time. That's why it's important for us to know that what we see right now is reflecting infection 2 weeks ago, and what we're going to expect in 2 more weeks is like exponential spread. Which gets us, I also wanted to say one more thing before I talk about the importance of social distancing. If you hear the term herd immunity, this is what that looks like. Those little open circles there, those are people who have not been infected. They are susceptible, but because they're sort of surrounded by other people who can no longer get infected, then the infection can sort of, they're in a little bubble of herd immunity, and the infection, if they remain surrounded like that, will not be able to get to them. In general, we think that herd immunity in a population kicks in maybe around 70% of the population being immune. And right now, we have no idea what our population immunity is, but I can guarantee you it is not 70% right now, because so many of us have been hiding in place so it doesn't get to us at all. So here's a chart, which is not my own, but it talks about the power of social distancing. This one depicts a 5-day, more like a 4-day doubling time. So one person at the beginning in 5 days, 2.5 people infected. By 30 days, 406 people infected in 1 month. If we just decrease that exposure by 50%, this is how it looks. Only 15 people infected at the end of 30 days. If we decrease the exposure by 75%, in 30 days, only 2.5 people infected from that one person. This is really why we are doing this shelter in place, social distancing, all of this. And this is why we have to continue. And anybody calling for us to break these things, because now it looks like we're past the peak, we are not gonna have like one peak, especially if we break all of this social distancing kind of discipline that we have right now. We're gonna have a tall peak and another tall peak. If we ease things out and do it well, then we'll probably have still a series of peaks, but they'll be much lower, and they won't be as overwhelming to our healthcare system as things are right now. I have just a few more minutes, so I'm going to just talk about testing briefly. And then if you want to hear more on testing from me and some of the new things we need to think about, then I'll tell you about where you can hear me tonight at 8 o'clock. But so here I've taken this infectious disease timeline for the individual. I am going to turn it on its head now. And now we're going to talk about infectious disease and the importance of testing and denominators in the population. So right now we are interested in the number of deaths. But if we just have the number of deaths, 27,000, I think you said now, Al, today, that number is a horrifying number, but we don't have any context for it. And so it talks about the importance of testing and denominators. We'd like to know how many deaths that is out of the total population. And we know that right now the US population is about 330 million. So we can figure that out. But this pandemic has not moved through our whole population yet. We know that. So the number of deaths are going to keep growing and growing. The cause-specific or COVID-19 specific mortality rate would be if you took the number of deaths over the total population. But what we really want to know is how many people are infected, right? And we have no idea, because the kind of testing we've been doing is a very medical care, individual. Somebody comes in with symptoms, you test to confirm the diagnosis type of thing, where we can document the course of the epidemic. But what I told you is, if we really want to know how prevalent this disease is in the population, we need to have a population-based public health surveillance strategy to actually I would say test everybody who wants a test, who feels like they have symptoms, or maybe they're curious, but also do a population-based test of those who do not have symptoms. That is the only way we're going to, or if we had all the tests in the world, we would test everybody. And for people who are negative, that doesn't mean they're going to stay negative, right? So it talks about a different testing strategy than we have right now. But right now, what we need is this widespread public health testing for surveillance, isolation, and contact tracing. What we have right now, we do have an estimate-ish of the symptomatic population that we're getting with our current haphazard testing strategy. We do know the number hospitalized, which is actually not the number who probably need hospitalization, because some people are dying at home before they get to a hospital, or perhaps in the prisons, or perhaps, you know, on the streets if they're unhoused. But we have a better sense of this, but this is the testing strategy that I was criticizing, where we're only doing it for patient care. Well, that's important for us to know if you have COVID-19 or do you have a bacterial pneumonia, because the treatments are different. No treatment for COVID-19, but yes, antibiotics for a bacterial pneumonia. It's also important if we're in a situation where our protective equipment for our healthcare workers is limited. So if it's a bacterial pneumonia, then you don't have to put PPE on when you go in that room. But I have to tell you, it is hamstringing us. We're using all the tests in a way where we are operating blind. We do not know what's going to happen in 2 weeks with this exponential spread. So if we really wanted to know what we call the case fatality ratio, that is how dangerous is this disease if you get it, the lethality, it does require knowing the total number of infected. We have no idea. So as I say, tonight on a Facebook Live event that my colleagues Hillary Beard, who is a journalist, and Phil Wilson, who is an activist, and we're now doing a weekly Facebook Live from Hillary Beard's Facebook, her professional Facebook page, Hillary Beard Author. I am going to be presenting more about the two kinds of tests we're hearing about now. So there's the test, are you infected, and the test, have you been infected? And I'm going to go very deep about what we need to know about characteristics of tests in order to interpret what we're going to be hearing in the next week. So thank you very much, and I'll stop sharing.
Great, thank you, Dr. Jones. We had quite a few comments and questions come through the chat. One question that came through was addressing about herd immunity. Does social physical distancing decrease immunity, which further increase our risk later if we do not have immunization later?
Yes, so what we're really waiting for, we're really trying to, I think of it as freezing the body politic until we come up with a vaccine or a cure. And you know, the rich people who freeze their bodies right before they die because they have some rare disease and they're freezing their bodies and want to be thawed when there's a cure. That's what we're doing to the whole body politic right now. That's what we have to do until we have a vaccine and it's widely distributed or there's a cure, honestly. That's why it's going to be 12 months, 18 months. It's not going to be the end of this month.
Great, thanks. And you know, given the stringent and restrictive testing criteria from state health departments, how can local governments advocate for population-wide testing?
Through Congress, to the governors too as well. Actually, I had the opportunity to speak to the health subcommittee of the House Ways and Means Committee just 2 days ago. And so I stressed the need for funding full testing. I understand that in Los Angeles now, anybody who wants a test can get it. And I also understand that Stanford University is now launching at least a kind of a surveillance of the Major League Baseball teams, and they're not just the players, but all the people associated to get some better sense of what's going on. But I have no idea why we didn't have a good test, and I do not know why the CDC seemed to have got muzzled or something. What I'm saying is something that every epidemiologist and every public health worker knows about the population-based public health strategy to testing, and something very bad is happening with our government.
Great, thanks. And I guess there's some specific questions around the infection. So there's one about what about the risk of superimposed bacterial infections?
I actually don't know, but I don't think that people are living that long if they get the bad pneumonia. So yeah. So it's a very sad thing. I'll tell you one thing. If you feel, this is something that I recently learned. If you're at home and you feel like slightly short of breath, that you can lie prone, and you could even put a stack of like a mountain of pillows and sort of lie with your feet down and your face down, like your stomach up high on the pillows, to help drain some of the stuff out of your lungs. But I mean, you really shouldn't be trying to do that. You should be trying to get to the hospital as soon as you can. But I think that it's moving so fast. People have walked into emergency departments and then in 2 hours they're intubated because it's just moving that fast.
Thanks, Dr. Jones. We have a couple minutes left, and I do have at least another question from Eve Rittenberg. Could you please talk about crisis standards of care, i.e. ethical guidelines for allocation of ventilator and other scarce resources? Advocates are calling for adjusting current guidelines to explicitly address the impact of racism on severity of disease, i.e. including adjustment for race, ethnicity, on top of the standard SOFA score and comorbidity score. What do you think would be the best way to do this?
So so this is an important and urgent thing, and everybody who's part of this webinar needs to weigh in with somebody. So honestly, what I think is that, first of all, definitely we should not be adjusting down for the existence of pre-existing conditions like hypertension or diabetes or heart disease, because we know that those things are so overrepresented in communities of color that even if you were to say we cannot use race or neighborhood or language or immigration status or incarceration status as something to either completely disqualify people or to give them a higher score, which is less, which is worse priority. They're saying we can't do that, but we want to use these pre-existing conditions because we want to maximize life years saved, or maximize the probability of survival. But that's just a proxy. So I think that we can't do that. And so this may seem naive, but I think this is a good starting point for us to think about. When I think about my 3 principles for achieving health equity, which are valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources, not equally, but according to need, I come down to what if we had a lottery for the random allocation of scarce ventilators. At least you would be valuing all individuals equally in terms of giving them a shot at life. And then once they get that shot, then you tweak the resources according to need there. I have a colleague, Dr. Michelle Holmes, who's actually at change.org. She has a petition to the Surgeon General, Jerome Adams, as well as Azar, the head of HHS, proposing such a thing because in her view and in my view, that is the only way that we can take out the impacts of implicit bias. We can take out the impacts of structural racism and the kind of residential segregation that has led to us having limited resources for health and excess exposure to unhealthy environments. So I suggest that you go to change.org and look at lottery as the only fair way for allocating ventilators or something. That's her whatever you call it, a petition, and see if you agree with that. It may seem naive, but I'll tell you this, if the president of this country thought that he really would be at risk of not getting a ventilator because it was going to be allocated by lottery in the case of shortage, he would make sure there was no shortage.
Mm-hmm.
And actually, I'll just say one more thing about that. We should not accept the scarcity frame. We need to say in this country, especially because the epidemic is not moving evenly around the country, that those areas that don't have a scarcity right now should be surging their materials, their healthcare providers and their ventilators to those areas in need, who will then reciprocate, so that we really should not be having local scarcity, especially in this country.
Dr. Jones, thank you so much for that incredibly clear and concise and effective description of this infection, and also for sharing your principles and for answering those questions. The truth is that COVID-19 is not our country's only health crisis. Some have had large-scale impacts and others have been more localized. And we feel that there's a lesson that can be learned from each of these crises. So today we're very lucky to actually have 2 guests who know firsthand about one such crisis, Dr. Deborah Holden and Ms. Ella Green Moten. And they have worked together and are 2 leaders that are working together in Flint, Michigan, and have worked together through the Flint water crisis. Dr. Deborah Holden is the Associate Dean for Public Health Integration and the Director for the Division of Public Health. She's Associate Chair for Public Health and Clinical Integration and the Professor of Epidemiology and Biostatistics at Michigan State University, College of Human Medicine. She also directs the Flint Center for Health Equity Solutions. Ms. Ella Green Moten is a longtime Flint, Michigan resident and community liaison at the Center for Public Health and Community Genomics at the University of Michigan in Ann Arbor. She's also an administrator at the Community-Based Organization Partners and Community Ethics Review Board. She's a community director for the Methodology Core for the Flint Center for Health Equity Solutions, and currently serves as a member of our National Advisory Committee for the Clinical Scholars Program. Dr. Holden and Ms. Green Moten, I'm hoping that you'll be able to share the trajectory and parallels between what we're seeing now with COVID-19 and health inequalities, and in terms of outcomes, and also how that your experience in Flint, Michigan, with a similar community disaster has galvanized you all in terms of your research and your partnership.
Okay. Well, thank you very much. And I wanted to start the conversation today talking a little bit about the community level experience. And actually talking about Flint, Michigan, and how we have been able to fare many storms. But knowing that we are a community that already was in crisis, and specifically talking about the Flint water crisis. Next slide. And so understanding that the crisis actually prompted what we call parachute research. So after the Flint water crisis was officially confirmed, which was probably around 2014, researchers and their institutions bombarded the community with research efforts. They wanted to come in and solve all of our problems. And oftentimes we found that those researchers were not connected to any of the community members, had no relationships with what was going on in Flint. And this situation actually it created an environment of confusion, chaos, disrespect, further mistrust for the institutions and the research in general. And actually, what we realized was that while this was brought to the forefront in 2014, the Flint community was already working on strategies of how to elevate the community voice. We had been, and actually Dr. Ken Key had been working on a community ethics review board probably since around 2010, but we were getting ready to roll it out when the water crisis hit. The Community Ethics Review Board is an organization that actually explores research, provides a review of that research or programs or services being proposed for the Flint community. And we do that by looking at the ethical issues of those programs. How does it benefit the community? How does it harm the community? And some of the goals of the community-based organization partners, Community Ethics Review Board, are to facilitate a community-based, community-driven review process, whereby research conduct ensures that the community needs and concerns about research are heard, projects are sensitive to the community culture, the feedback loop is provided, which means the results back to the community for its use and benefit, a written critique back to the investigator. And so fast forward, 2020, here we are again, but with a different crisis, the COVID-19 pandemic impact. And understanding that as a community person, I can't think about this just as what's going on in my community. I have to think about it as what's happening to the world, what's happening to this country, what's happening to the state of Michigan, what's happening to the city of Flint, what's happening in my household, and what's happening to me as an individual. I can't tell you the number of times that we've heard that friends have lost their lives because of this pandemic. And sometimes feeling paralyzed, but realizing that and hearing the information from our trusted researchers like Dr. Kamara Jones and Dr. Deborah Furholden, realizing that we're living in a survival mode. And the things that we need to do in order to make this work, starting with, we have to take care of self. If I'm going to be any good to the folk in my household, I've got to be around to do that. So I need to be adhering to those cautions that I get, to wash my hands, to practice the social distancing too, stay at home, right? And then I have to help my family members understand that they too need to be doing that we need to be wearing masks when and if we go out of the house. If we don't have to go out, stay at home. Taking care of extended family. And we know that we can't rush to anyone's home to take care of them, but we can talk to them. We need to be calling them, checking in, and taking care of the broader community. There are folk who don't have family members that we need to be concerned about. So we need to be about sharing what we have to take care of this whole community, and I'll say this whole country. And thinking in terms of community organizing in place. You know, we talk about shelter in place, but we have to be thinking about community organizing in place. We still do what we do. We still have to be protective of our community. Things still have to happen. So we need to stay connected. And if we don't understand the information that we get from our academic partners, we need to have that explained to us so that we can explain it to other folk. We need to stay informed, while it's hard to listen to some of the folk who get in front of the mic, we have to do that and trust that somebody's gonna come behind that person and clean it up, and usually they do. We need to stay informed. We need to share that information. Don't hog it. You know, we need to help people understand this is serious. I just learned yesterday that a very close friend died after having spent a lot of time taking care of her mom who died 2 weeks ago. She's gone. We have to check on others. We have to be sure that we don't allow folk to just be left unprepared, uninformed during this time. So we, as community members, as individuals, we need to be strong in this, as afraid as we are, as angry as we are, as paralyzed as we might be. We still have to help move this forward, because I have a goal of making it to 100. So I don't plan to allow COVID-19 to take me out. So that means I can't be hard-headed. I have to be about paying attention to what's in the best interest of me and those around me. Thank you very much, and I hope this talk has been helpful in seeing how we might do some things locally. And I know that my partner, Deborah, is going to come forward and talk about those specifics and some statistical facts. Deborah. And if you're talking, you're on mute.
Can you hear me now?
Yes.
I was doubly muted. I had the mute on the screen, and since I'm controlling the slides, I wanted to be safe. You couldn't hear any background noise. So I'm Deborah. Thank you all for the introduction, and thank you, Dr. Jones and Ella, for the great setup. I want to talk a little bit about unpacking some of the disparities that we've seen during the COVID-19 pandemic. I want to just give you a quick distinction in thinking about disparities versus inequities. The first thing is that when we talk about disparities, I always like to give people the synonym. And so disparities are really and I'm trying to move this out of my way. Great. Disparities are really the differences that we see. You know, we hear this group has a higher rate of this than that group. Those are differences. Those things are typically downstream. And oftentimes the interventions that we develop out of a disparities model are really typically person-centered. The equity framework, however, by contrast, and inequities in general, deal with the things that Dr. Jones talked about, which I consider to be a synonym for inequity to be unfairness. And these are mostly dealing with the upstream factors and the systems and structures that give way to the downstream disparities that we see. So if you think about matching the level of the problem with the level of the solution, in an equity framework, the solutions are focused also primarily on systems and structures and some of these macro level factors. Dr. Jones talked a little bit about racism and institutional racism and structural racism. That would be an example in that vein. And I always share this with people. We talk about framework. I love this depiction because it talks about equality. You can see you got 3 folks here trying to see the game. Everybody got the same thing, and you can see they still don't have equal access to the game. In an equity framework, people are really provided what they're needed. And so you can see here, the shortest person actually got 2 boxes so that he has same eye level view as a person who doesn't even need a box because he's already tall enough to see over the fence. To be distinguished from the social determinants framework, and I think that's where a lot of our work is headed. It's somewhere between equity and social determinants. That's really about moving all of the systematic and structural barriers for people to have access to what they need to be healthy. So you've all heard COVID-19 is disproportionately affecting African Americans. I'm not going to reiterate these stats. I'm going to provide these examples and say bravo to Illinois, Louisiana, and Michigan for being early in the fight to actually produce and provide this data by race. We can imagine that these disparities, these downstream differences and outcomes that we're seeing are more prevalent than we know, but at least these states took the early step to put that data out by race so that we can understand. The take-home point here is you can see, if you look at the percentage that African Americans, and I'm going to focus on African Americans, not because we're the only disparate population, but because it has become overwhelmingly and apparently clear that there is a huge disparity in COVID-19 outcomes for African Americans. The point here is that while we represent whatever percentage of the population we represent, we are very much overrepresented in the worst outcome of COVID-19, which is death. You may have seen some of these articles. This came out on Sunday. You can see it was 58 degrees in Flint on Sunday. And at that point, these numbers have changed a bit, but at that point, all 12 COVID-19 deaths in St. Louis were all African American. People would be up in arms if you inserted any other demographic in that sentence. But I offer that health disparities are actually the status quo in America. People of African heritage have experienced health disparities from our passage into the Americas and since we have been in the Americas. So this is status quo for us. I also applaud Massachusetts, who has a very interesting healthcare system that is marked by big disparities, but they at least have come out. This is another article that came out over the weekend in the Boston News, where they say that their ventilator and bed rationing guidelines, by the way they're designed, and Dr. Jones touched on this, are prioritizing whites over patients of color. And I'll talk a little bit about why I think that is. I think we've looked at the usual suspects. We've used things like pre-existing health conditions. You know, we say, oh, well, African Americans are more in these essential service roles that come with low protection but high risk, like food service delivery, security personnel, maintenance staff, orderlies, high demand, low protection, frontline healthcare positions. We've talked a lot about African Americans dying at home and being unwilling to come in for care because of medical mistrust. We've talked about misinformation or misunderstanding of the protocols and public health recommendations. And then we started to talk about social determinants of health. But I'll tell you, my problem with the conversation, even about social determinants of health, is that we've pointed to things that we have zero ability to impact right now. So when people say things like African Americans have a higher death rate because of poverty, that might be the case, but we can't do anything, and we're not going to do anything right now to impact poverty. So even in the conversation around the social determinants of health, I think the call to action is to start to elevate that conversation, because these explanations have been used in what I'm calling algorithms, the background thinking, and in some care settings, there are actual algorithms where you input information about people, and that is used to prioritize the care that people get. The decision of whether or not they are admitted or sent home, whether or not they are prioritized to get a bed. There was an article that came out in the Detroit Press over the weekend about 2 patients dying on a gurney in the hallway of the emergency department. And by the time people realized they were dead, they had been dead for quite some time. So I think that we've accepted these explanations, and I think we've unfortunately accepted explanations that are not actionable. And these explanations have influenced the algorithms, like I said, for who gets what, prioritizing people for screening and mobile testing and hospital admissions and life-saving procedures such as people getting a DNR or a do not resuscitate code status assigned to them because they've been unfortunately viewed in the medical system as not the best use of these limited resources. I believe that these algorithms and these explanations are attributable in a large part to the excess morbidity and mortality that we're seeing among African Americans and literally are killing people. So what are some of the solutions? I love Dr. Jones's bold, audacious idea of a lottery. I love it. I think we need to reorder it. So instead of prioritizing things the way we've done it, what if instead we turned risk into priority for the continuum of care? So what if having a pre-existing health condition didn't make you lower in priority, but made you a higher ranked priority for screening and testing? Similarly, if you are in a high demand, high risk exposure position that we know is typically under-resourced and has lower protections, you should be higher on the continuum of care and higher in priority rankings for who gets what. Same thing, medical mistrust. There are right now mobile testing sites that are available, but many of those sites require that you have a script from a primary care physician. So if you don't have that, and you came into COVID-19 without a primary care doctor, instead of that making you lower priority, that should mean you would be higher priority because you already have an existing risk factor that puts you in excess harm's way if you do test positive for COVID-19. Some of the critical takeaways, I think we need to stop describing the problem and start implementing solutions. We need to map those solutions onto priority versus using them to establish variation in standards of care. We need to focus on the factors that we can control and impact and stop blaming the disparate and pointing to the populations most impacted and pointing at their individual risk factors. We need to bring the health equity lens, and we need to use data to inform actions and interventions. As an example, African Americans are historically less likely to report wanting a DNR and less likely to sign a DNR. Primarily, we have high levels of medical mistrust, poor patient-physician communication, and historically, and there are multiple studies that cite this, we then want every life-prolonging procedure because we have, to me, very valid mistrust of a system that is not always acted in our best interests. We need to be looking at the data. Are African Americans now disproportionately being assigned a DNR status during this season when typically family members and people who have advanced directives and medical powers of attorneys are now not allowed in the hospitals to effectively advocate for the kinds of care that we know people want? And lastly, we need to strengthen the public-private partnerships. I applaud all of our great medical personnel and frontline staff who are dealing with these problems, but I know many, many public health people who are fighting and begging, put me in the game, coach. We can be doing that work and helping them make sense of their data in real time. I want to acknowledge that African Americans are not the only disparate populations in this. There are many others. Prisoners, we've all heard about off-label medication testing that's happening with hydrochloroquine in prisoners, et cetera. Other institutionalized populations, the elderly, people living in assisted living facilities and nursing homes, the poor, sexual minorities, people who were uninsured pre-COVID and remain uninsured during COVID, the elderly and undocumented and non-native English speakers. This is not an exhaustive list. My point is, Houston, we have a problem. I think the case of African Americans has shined a light on it, but I imagine that there are other likely disparate populations. Last point, some policy initiatives that I think are absolutely essential. And Dr. Jones, I will check out that site that you recommended. We need to focus on equity-driven access. Equity-driven access in testing and hospital admissions, in critical care, things like DNR. We need equity-driven protections. 45 CFR Part 46 calls for special protections for institutionalized and imprisoned populations. I do not think we should be doing off-label medications testing in prisoners and other institutionalized populations. We also need equity and resource allocation. I had a very smart, well-trained physician say to me, who runs an FQHC, well, FQHCs have received dollars and those dollars have been rolled out, and there's no inequity built into the money that we received. And what I said to him was, even if inequity is not built in, inequity is the natural drift of things. That is the natural order of how things go in America and in our healthcare system. So it's not that we can accept policies or resource allocation where inequity is built in. We have to be a demand that equity be built in. If you are receiving money for federal dollars for mobile testing, you should be required to have an equitable process for who gets access to that. And having criteria like you have to have a script from a primary care physician necessarily excludes a lot of people from that. The funding must require equity. I also think this is not the kind of thing that we are in a position that we can Monday morning quarterback. We have to be proactive versus reactive, or do some post hoc analysis to understand the disparities after they've happened. The time is now, and we've got to implement those measures now. Thank you.
Thank you so much, Dr. Verholden. I know you hadn't had a chance to look at the chat, but it's engaged a lot of conversation and discussion, and we do have time for about 1 or 2 questions. And so to reframe it back to this idea of this webinar, which was around not only equity, but also partnership, I think there was a question about how do we translate this information shared in this webinar and in future webinars back to our communities, because we think we're finding this information be so important for us, but how do we bring it back to those that don't have opportunities to see this recording and may not have the time or ability to learn more so that they can help out where they are. And I guess I'll open that to any of the speakers.
I was being really brilliant on mute. Oh, technology. I will say I don't think there's one answer for that. I can tell you what we've done in Flint. I know that a lot of communities have already, like the Flint water crisis was a major source of stress and trauma. It was an example of racism and environmental racism at its finest. What happened in Flint would have never happened in some of the other cities in Michigan that are wealthier and whiter. So one of the things that we, Ella talked about that CBOP-SERB, that Community Ethics Review Board. Well, that's in a partnership with a very large multi-institution community-led initiative called the Healthy Flint Research Coordinating Center. We host a weekly webinar, and we are now entering our 5th week of doing that, where we get key leaders from all across the city to explain and break down for people what's happening, what does it look like in our local community, what resources are available, how you access them. We then give people an opportunity to chime in and say, that didn't make sense for me, or I tried that, or even though there's a stay of eviction orders in Michigan, my landlord came and changed the locks on my apartment. So we are using a grassroots, ground up approach to get that message out to people in the communities that we serve. But we were able to do that because we were already connected to community. I don't think that this is going to be a one model will fit all. Messages that might resonate for people who have good working internet in this webinar format is one thing. I think we need to be really creative, no holds barred, and getting the word out to people, and be willing to hear the feedback when they say, that doesn't work for me, or that doesn't make sense to me. We keep using the word social distancing, and a lot of people still don't even get what that means. They didn't go to church on Easter Sunday, but they hosted a 30-person Easter dinner at their house. And in their minds, they're adhering to the protocols. So I think that the responsibility is actually on us, the public health community, to do a better job of grassroots efforts and to have messaging delivered to people in ways that make sense and meet them where they are, and that also are sensitive and relevant to the population.
Thank you so much, Deborah, Kamara, and Ella. This was a fantastic way, as someone has chatted in, to spend an hour. I just want to close us out now and let you all know that you should be checking out the discussion board on CCPH's website to continue this conversation. Our next webinar in this series will be next week, and we will be sending out information about specifics and ways to register for that. Please, because we really want to hear what's working, what's not working, and as well as topics that you're interested in hearing about, please go ahead and either use this URL to give us some feedback, or you can use the QRS code here. And just thank you all for joining us this afternoon. We've had an incredible time putting this together, and look forward to continuing the conversation. We also want to thank our co-sponsors, the Clinical Scholars Program. So thank you all, and please stay safe, and look forward to seeing all of you all next week.